I would like to thank Dr. Durga Das Asrana sir, President of Kasoga, and Dr. Shobha Gudi ma'am, Secretary of Kasoga, for giving us this opportunity to conduct the webinar today. It is my honor and privilege to host this webinar as part of the Endometrial Cancer Awareness Month, which was in June. I'm Dr. Prerna, Senior Registrar in the Department of Gyneco-Oncology, working under Dr. Rupesh N, Lead Consultant and Gyneco-Oncosurgeon, PIPAC HIPEC Specialist, and Laparoscopic and Robotic Surgeon in Bengaluru. He's also the Chairperson of Gyneco-Oncology and Preventive Oncology Committee. On behalf of our team, I welcome the esteemed faculty for today's session. I welcome Dr. Sarita Shamsundar ma'am, Professor and Unit Head of the Gyneco-Oncology Department at Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi. I welcome Dr. Bhagyalakshmi Nayak ma'am, Professor and HOD, Acharya Harihar Regional Cancer Center, Cuttack, and also Chairperson of Young Gyneco-Oncology Committee, FOGSI. Dr. Shobha Gudi ma'am, who is a Senior Obstetrician and Gynecologist in Bangalore and also the Secretary of Kasoga. Dr. Santosh Devdas sir, Professor and HOD of Department of Medical Oncology at MS Ramaya Cancer Hospital, Bengaluru. Dr. Aparna Ganguly ma'am, Lead Oncopathologist and Founder of Phoenix Oncopathology. Dr. Ajay Rao sir, Senior Consultant and Medical Oncologist at Fortis Hospital, BG Road. Am I audible? Hello? Hello?
Yes, you are.
I welcome all the attendees of the webinar as well. Over to lighting of the lamp and prayer, which will be handled by Mr. Arun.
Kurutvam kalyanam arogyam dhanasampada Shubham kurutvam kalyanam arogyam dhanasampada Shatru buddhi vinashaya Deepajyotirnamostute Deepajyotirnamostute Shubham kurutvam kalyanam arogyam dhanasampada Shubham kurutvam kalyanam arogyam dhanasampada.
Thank you, Mr. Arun. I invite Dr. Rupesh to welcome all the participants.
Yeah. So good evening, one and all. It's an honor and privilege to have a wonderful team of people who are have had years of experience and have had multiple laurels in their professions. So firstly, we have Dr. Aparna Ganguly, who's going to be our first speaker. Madam is the head of Phoenix Oncopathology Labs in Bengaluru. I'm sure, Prerna, you can open Madam's CV and you can please, yeah. So Madam is the founder and lead of Phoenix Oncopathology at Bengaluru. She brings about 26 years of oncopathology experience. Having started her career in Kidwai, she moved on to work at other premier hospitals such as Mazumdar Shah Cancer Hospital, HCG, and Site Care. So her areas of interest is FGT pathology and soft tissue sarcomas. She has various publications to her credit and has conducted many IHC workshops for postgraduates. So we will be beginning with Madam's talk, Dr. Aparna's talk on the recent classifications. Over to you, Dr. Aparna, please.
Yeah. Am I audible?
Yes, you are, madam.
Yeah. Thank you so much, Kasoga, to having given me this opportunity to share a bit of my experience and to focus on modern classification and management of endometrial carcinoma. Management part, of course, I don't have to emphasize since you're all clinicians. Now, I've been given only 15 minutes and let me get started straight to the point. Endometrial carcinoma, as we know, has seen a lot of classifications over the years. And the risk factor stratification also has changed over the years. To recapitulate the traditional risk assessment, we used to rely mainly on the histotype. That's the histology, whether serous carcinoma or endometrioid carcinoma or clear cell carcinoma and such. And then grade 1, 2, 3. And then lymphovascular space invasion and tumor stage. Right? Now, I'm not saying that these are out of fashion. These are still very important. These will never go out of practice. These will be considered forever. However, in addition, we also have the molecular classification. The molecular classification is now done as a reflex in many centers, and that's what I would recommend. Now, endometrial carcinoma is not a single disease entity. As we know, we have low-grade types and high-grade types in that. So initially, high-grade and low-grade.
Ma'am, could you
was
please
dependent.
share your screen, ma'am?
Screen sharing is not happening?
No,
Oh, I'm
ma'am.
so sorry. I'm so sorry. I'm so sorry. One second. Just a second. What happening? Dr. Rupesh?
Yeah.
Yeah, it's the same PPT you also have. Is that possible for you to share? Can that happen?
Let me check. Yeah, I will try.
Yeah, I think madam has to be made co-host. Arun ಅವರೇ help ಮಾಡ್ತೀರಾ?
No, I have shared one copy with him as well. Let's see if he can do it.
Madam, anyone can share it.
Host and co-host
Yeah.
can.
Yeah, I have sent it to you, Arun. I'm ಕಳ್ಸಿದ್ದೀನಿ ನೋಡ್ರಿ.
Okay.
Sorry for the inconvenience. Yeah.
Is it visible now?
No, your video is not yet visible, madam. I think.
Second.
Arun, it's happening. Is it happening or like anything we have to do?
Downloading, sir.
I think if they, even if she doesn't get the presentation, she can as well talk also.
Yeah, exactly. I was about to say.
Actually,
that.
you have to make her as the co-host. There are only host and two co-hosts. If she's made a co-host, she can share.
Okay,
Sir,
no,
anyone can share it. Sir.
Yes,
I think
I will do it.
it's
I will do it. Yeah, I will do it
Yeah,
right away.
now it's co-host, sir. But anyone can share it, sir.
Yeah. No, I'm pasting it.
Okay, no, I won't waste your time any further.
Yeah, I think now it's
I continue
yes, there you are.
explaining.
There you are. I think you can see.
Yeah.
Can everybody see the?
Yes, sir.
Yes, sir.
Yeah,
You can
please,
see.
please,
Yes, sir.
madam, please go ahead.
Yeah. So, like I said, we have shifted now to molecular classification in addition to the traditional parameters. Now, endometrioid carcinoma is not a single entity. When we say endometrial carcinoma, we include the conventional classical endometrioid carcinoma, then the serous carcinoma, then clear cell carcinoma, right? So, initially, the difference between these were pure morphological. Now it's not so. Ever since we discovered the role of P53, the pole alter mutation. Am I audible?
Hello.
Yes, you
Am
are
I
audible,
audible?
ma'am.
Yeah. Okay.
No, actually, the screen, it is not showing single slide, it is showing multiple slides.
Okay, I'll just read out the title so that we'll know which slide we are on. Shift to molecular classification. That's visible to everyone.
Yes, that's visible. That I mean, it's coming as multiple slides together.
Yeah.
It's not coming as a slide because I think it's the URL that is posted. So maybe as a PDF it's coming rather than a slide presentation. I think I think we can read the shift to molecular classification slide. Yes.
Whoever has shared, just double click on the slide, please, which has been.
Yeah. Then that may become a single slide.
Yeah, slide number 3.
Yeah, I'm trying to double
And expand it or something.
Can I just expand it?
Yeah.
No.
Sir, you might have taken that multiple slide this thing in your laptop.
Okay. Let me just be sorry. This is actually okay. Otherwise, Arun, or can you please make Madam as the co-host? Or how do
It
we
has
do
been
it?
made actually. It has been
He
made.
has made him a co-host.
Okay,
Made
now
her
tell
the
me what to
co-host.
do. Because the whole PPT is in front of me. It's open here.
You share
So
the screen.
You have to
yeah,
share.
share it. I've clicked on share.
No,
Next.
share
Then
screen.
Yeah, it is coming actually. Yeah.
coming now.
Yeah, but still,
No,
wait.
I have stopped my stopped sharing from my end. So now, mostly Madam can.
Is it better now?
Dr. Rupesh, you can share the slides and she can speak. Why don't you, she send the
Yeah, let's do
slides to
that.
you?
Yes, I did it, but she has sent it in the WPS software thing, which when I'm sharing, it is coming as slides. As PPT slides, and multiple things are being displayed, not as a single slide. I'm unable to do it because she has sent me in a different format. Maybe if she sends to me in a PowerPoint.
No, doctor.
No, irrespective of the slide sequence, I think she will do the talking. We will listen to her.
I think that's fine because we all know the background of the molecular classification by this time, right? So what I'm trying to say is we have to do this as a reflex. The molecular classification is also known as we include 4 things in this. One is pole hypermutation, then microsatellite is MMR. What we do through IHC is MMR. What we do the same thing through PCR is called as MSI. We test for MSI instability.
I'm not able to see the slide at all. Earlier, I could see it.
Yeah, I will.
Now,
I will put it
Dr.
again, Madam.
Aparna is also not visible. Madam, you
So I'm
just
also
on
not
your
with
video.
No, earlier it was multiple slides were
Pushpa
visible,
ma'am,
but now
Pushpa madam, slide they are not able to display. So we are requesting her to continue with the presentation.
Mr. Arun, can you share the
Start her
PPT
video.
to me? Yeah, Mr. Arun, can you share the PPT to me? I'll try sharing from my laptop.
she can talk.
Ma'am,
Then.
I had said you
Yeah,
then.
yeah, yeah.
Yeah, it's
now is this
better
okay?
now.
Now
Yeah,
it has
Yeah,
come.
yeah.
Yeah,
It
slide
had
number
come.
4. Please go ahead.
Okay. Now, this is a TCGA. That is the TCGA stands for the Cancer Genomic Atlas based molecular subtypes.
I can't
First
see
one is
the
the
slide at all.
Madam, you just on your VPS AI.
No, but it in between I saw small, but
my
screen
VPS
share.
AI is on.
Now I can see.
Okay.
The slide visible now?
Yes,
Now
Yes,
yes.
we can
slight
see.
visible and clarity is better. Just adjust the clarity.
Yeah, I think you can just magnify this the slide so that each slide is seen separately. The
Magnified?
screen, you can just magnify.
I have magnified from my end.
Slightly
Yes,
better.
yes.
Okay, it's
Okay.
better, madam. You can carry on now.
Okay. So the Cancer Genomic Atlas based molecular subtypes. Why do we need these subtypes basically? Is this just for the sake of academics or research? Not really, because they do have a bearing on the prognosis. Directly, they dictate the prognosis. First one is pole mutated group, which these cancers carry excellent prognosis. Second one is the microsatellite instability group, which has intermediate prognosis. Third one is the copy number low group, which has intermediate prognosis, and copy number high, that is the P53 mutated group, which has a very poor prognosis. Now, generally, for all serous carcinomas, endometrium, the ultimate proof is by doing P53, and it should be mutational type expression. Wild type expression is not considered as P53 positive. Okay, where what is significant P53? It's the mutant type. So generally, when you see a P53 report on IHC, it's never positive or negative. It's wild type expression or mutant type expression. So mutant type expression is the one which carries poor prognosis. Now we're coming to slide number 5. I hope this is visible. Clinical integration of molecular testing. Now, surrogate IHC plus pole mutation testing is practical.
Hello. Hello.
Yes. Yes,
Hello.
madam.
Madam's voice is not audible.
Who's
Hello.
Dr. Aparna's voice?
Yeah. You
No,
are
it's
No, it is.
audible. It's
It
audible.
is very audible. It is very well audible.
I don't know what happened.
You can check your internet connection, madam. Maybe your
Madam,
internet
you
connection is
both are
weak.
audible means.
True. Yeah.
Yeah.
But
Please continue.
Dr. Aparna,
Will
please
not
continue.
disturb you.
No, that's okay. I'm really sorry because we had so many hiccups. So yeah, what we do practically is surrogate IHC and pole mutation testing. In the sense, pole mutation is done by NGS. All right, that's the best way to do it. And the rest of the parameters, that is MMR and P53, they are done through IHC. So in a practical setting, when you have an endometrial carcinoma, either on curettage or after hysterectomy, what we do immediately is the IHC. So IHC report you should get between 2 to 3 days. That would be MMR and P53. However, pole mutation is done through NGS, so that could take anywhere between 10 to 25 days, depending on the provider. Now, this panel of IHC and PCR is especially valuable for grade 3 endometrioid carcinoma, because sometimes grade 3 endometrioid carcinoma, although it is a endometrioid carcinoma, it can still have mutant type expression of P53, wherein it will carry a very bad prognosis. Now, best results combined with histological and molecular analysis. So, regardless of the number of molecular tests we have, histology carries its weight, and it should not be disregarded ever. Now, WHO 2020 classification had new tumor types like mesonephric like adenocarcinoma and gastric type mucinous carcinoma. Both of these are adenocarcinomas. Now, the additional thing is carcinosarcoma, which was mixed Mullerian tumor, is now a part of endometrioid carcinoma. There was a time when carcinosarcoma was classified under MMMTs. It's not so anymore. This is very much a part of endometrioid carcinoma group now. Now, coming to FIGO 2023 staging, I will not go into the details of this because you are all very well aware of this, but I'll just try to link the salient points with the molecular classifications. Now, if you see in stage 1, this is the latest classification. In stage 1, a lot of emphasis has been given to the histology. It's not just about the extent of invasion or lymph node involvement, that is there, of course. The kind of the histology also has taken a very strong position here. Now, if you say 1AM, pole mutant, you can see it's pole mutation, pole mutated, confined to corpus or cervix. The link between the staging and the moleculars I have highlighted in red. Stage 1C, aggressive histology confined to endometrium or polyp. Now, what do we mean by aggressive histology here? It's either serous carcinoma or endometrioid carcinoma, grade 3, both of which they may or may not express or have mutant P53, but this histology of grade 3 endometrioid carcinoma and serous or clear cell carcinoma is considered as aggressive histology, and this impacts the staging. It becomes 1C. Similar 2C, aggressive type with myometrial invasion is 2C. 2A is non-aggressive histiotype with cervical stromal invasion. 2B is substantial LVSI in non-aggressive types. So what I'm trying to say is aggressive or non-aggressive now has a definite place in staging. I will not go through the entire stage 3 and stage 4, which you are well aware of. So to summarize and to conclude, transition from histological to molecular staging, this has improved precision in treatment planning. FIGO 2023 and WHO 2020 changes reflect evolving understanding and the impact of molecular classification. So the moral of the story is, whether it's on curettage or hysterectomy, the choice is yours, but you have to ask for molecular studies in every single case of endometrial carcinoma. Traditional histology and grading is not enough. That's the point I'm trying to make. Thank you so much for your patient hearing.
Thank you so much, Dr. Aparna Ganguly. It was a fantastic, although concise, it was so comprehensive in terms of what each one of us needs to know, because as you said, the traditional understanding or traditional reading of the pathology report by the gynecologist is something that we need to evolve as gynecologists in terms of, be it the endometrial biopsy report or the final histopathology report after the hysterectomy and the lymph node dissection. So, yeah, would be happy to have questions from people around before the final comments are made.
Can we ask? Hello,
please, madam.
Dr.
Please, madam.
Upesh. Whether all the type, if it is a grade 3 and it is only endometrioid, also needs to be evaluated by molecular way.
Yes.
Yeah.
Yes.
Okay.
Yes.
Okay.
Because if it turns out to be P53 mutant, it will have a it will have worse prognosis than an ordinary grade 3.
Okay. So suppose can we predict this thing metastasis on this background, early metastasis or anything on molecular basis study?
As such, it is more than the predicting the metastasis by this. What we need to understand is the aggressiveness of the tumor, wherein the simple ones or the complex ones, see, these are very easy. Like a 1A grade 1 or a grade 1, grade 2 tumors, anytime it's easy. whereas
Mhm.
the advanced ones, that is stage, FIGO stage advanced like 3, C2, and high risk stage 4 are also easy, unambiguous. But
Mm.
main thing what we need to know in these kind of tumors, wherein the in between, why there has been so many sub-classifications, what Dr. Aparna beautifully said, that is the individual ramifications that have happened is because when we see in the long run, there has been a lot of studies that have been made and elicited that the type of failures may vary, especially what Dr. Aparna is trying to emphasize upon the P53 is and the aggressiveness of the histology is that these are the types of tumors that can have a systemic failure rather than local failure. So systemic failures, that is like they may fail in the peritoneum, they may fail in the unaddressed nodes. They may. So this is how. Very rarely we have also seen some spinal metastasis. So rather than molecular straight away having an upfront metastasis, that's not the point. So, but yes, of course, all advanced cancers will have a bad molecular histology, like what she said, the 1, 2, 3, 4. So the fourth one, that is the poorer ones, the variants are the ones. So all advanced stage 4 cancers can have or will have the bad elements. If Dr. Aparna can throw more light on that.
Yeah, I would like to emphasize on one more point here. Serous carcinomas or any carcinoma which is mutant P53 positive, even if it is not invasive, okay, even if it is confined to the epithelium, in the sense confined to endometrium in this case, right, it can still metastasize.
Exactly.
For example,
That's
serous
what.
intraepithelial carcinomas,
Yeah.
what we call as
True.
SIECs, SIECs,
Yeah.
whether in endometrium or whether in tube, for that matter, even in fallopian tube or in cervix,
Mhm.
okay, even if they are confined to the epithelial lining, they can still metastasize. They have that power. And one fine day, you even if you see them metastasizing to peritoneum, a patient coming with peritoneal mets, don't be surprised. We have seen many cases where it is confined to polyp, and then people think, okay, it is anyway confined, it's fine, what's the big deal? It's fine
Okay.
if it is confined, it's very safe. It's not safe. Not serous carcinoma, these are notorious. Even if they
Okay.
are intraepithelial, we have seen patient coming back with peritoneal mets.
Yeah, hello.
Oh,
Hi,
yes.
this is Dr. Ajay here. I'm a radiation oncologist, and I wanted to make a point here that to the question whether we need to do the molecular analysis for endometrium, I would say that irrespective of the stage or whatever 1A, 1B, we have to do the molecular pathology because now, as Dr. Aparna said, even in 1A, which is confined to the endometrium, if there is a P53 mutation or there is L1-CAM or NSNP kind of a thing, now the guidelines have changed and post-op treatment will be required with radiation. So there was a question here which I am seeing by Dr. Jairaman whether the pole mutation positive means it is later post-op. Pole mutation is a good prognosis. So we can we can de-escalate the treatment. But when it is P53 mutated, even in a stage 1A, according to the latest Portec 4A, there might be a time when we have to look at treating it aggressively with adjuvant treatment. So the emphasis here is irrespective of the stage, the moment it is endometrial carcinoma, we have to do the molecular pathology. It will go towards that, like how we do it in breast, where ERPR and HER2 are compulsory. It would be going towards that in endometrial carcinomas.
One more thing I would like to ask, because we have Dr. Santosh Devdas, that in pole mutation positive status, that will override, I think, P53 and MMR, right?
Thank
It's a
you,
good thing,
Dr.
no?
Hello? Hello.
Yeah, hello, Dr. Santosh. Yes.
Yeah.
You're right.
So, as you rightly pointed out, Dr. Aparna, the pole mutation is the first test that we need to look at. It overrides all other mutations. If,
Yes.
for example, the patient is pole mutated and also P53 mutated, then the pole mutation overrides the P53 mutation, and we take the patient as a good risk in terms of outcomes. and we tend to downstage and kind of avoid additional extra treatment that may be unnecessary in some
Yes,
of these patients.
precisely.
However, I think but the FIGO
Yeah.
hasn't any recommended
Yes, I
changes in the
think yes,
management
exactly. I was
based
just
on
going to tell
the
that. Yes.
and so there are only recommendations, and the ESGO has given some guidelines on the adjuvant therapy based on the molecular, but there's no, I mean, it's not completely, there are some recommendations, and I will come to that in my
Yeah, I think you
presentation
have
on the
to,
management. Yeah.
every case has to be managed as an independent case, because
Yes.
if we really think that she's P53 positive as well as polymutant, and we really de-escalate, then maybe sometimes we will be in problem. So I think each case has to be weighed according to its own merit. And we have to see so many other things as well, your LVSI, my vision, size of the growth, and so many
Yes.
other things. So
Yes.
if you just see the polymutation and change your treatment, I think we will be in a soup.
Yeah,
And
I
the
would
other
like
thing is
to.
about molecular, there are, except for poly, which is only by NGS, the others can be, Dr. Appanna, I think we can, by the
IHC.
P53 and yes, by the
IHC, that can
IHC,
be done
it's,
by
yes.
IHC. But the thing is, the more you ask for this panel, this is called endometrial cancer panel, which includes pole mutation by NGS and P53 and MMR by IC. Okay, that we all know. But then the more you ask for it, the faster the prices will come down. Generally, the objection I hear all the time is that, doctor, it is so costly. It is like 35K, 30K. But then you see, NGS is expensive because not too many people ask for it. If everyone starts asking for it, okay, as a reflex, trust me, you'll see a difference in 6 months in the prices.
No,
Also,
Dr.
it has to
Appanna,
be
it's
done in
not
the
a reflex.
standard
It has to be done. It's not
and,
a
and the
reflex.
validated.
So for the newest staging system, it has to be done. Right.
Yeah,
No,
but
it
the
is
current,
validated.
I would like to interrupt here. Current consensus in the FIGO, I mean, for all the gynecologists out here, like the current consensus is that for the low grade as such, it is optional. Of course, we, as a gynec oncologist, almost all the cases of endometrial cancer I operate, I do send, I do ask. But currently, it is the higher stage, the high risk category, you ought to ask it. But the low risk, it is optional, is according to the FIGO, the ESGO guidelines. So this is what we will, but I'm sure that the message to everyone is very well conveyed, that endometrial cancer is no more just the same cancer what it used to be in terms of, yes, this goes only for adjuvant radiation, this goes only for vaginal brachytherapy. That's not just any more of it. There is more to understanding, and I'm sure that all this futuristically will lead us to even more subsets of patients who are going to benefit, just like we saw that the pole mutation benefits, I mean, is much better than the non-pole mutated. So with this, I think we will come
Rupesh,
to.
I just need to add a little. Even in a low grade, I think we will have to request everyone to do at least a ERPR P53,
No,
because
that
you
is,
never know that low grade is a low grade.
I'm not sure about the role of ERPR. I think Dr. Santosh can elaborate how important.
No, madam, ERPR has a lot of prognostic significance, because whenever you have a ERPR positivity, that means they are a well differentiated tumor. And of course, for the treatment management and all those things, they will help. But I think now the NSMP with ER has actually a great role now. So I think
Yeah.
ERPR is that was the age old thing that we were doing, and I think that should also be
Definitely.
done now.
But as per the, I told about the ESGO guidelines, madam, that if you ask in a pathology, the mandatory things is what, now we are discussing about this. But yes, maybe in an institutional place wherein you are doing it as a complementary, definitely no wrong in getting that done. So excellent. Thank you so much, Dr. Appanna, for the wonderful.
Thank you so much. Thank you so much.
Yeah, so one wonderful elaboration of a very important aspect, what the pathologist needs to, what the gynecologist needs to know from the pathological aspect.
Hello,
Now,
Rupesh.
Dr. Yes,
Rupesh, Dr. Shobha Gudi
please, madam.
joined.
Namaste. Tell me,
Namaskara,
madam.
namaskara. Is listening to the discussion. Yes, the panel has started, or was this the talk?
No, this is the first talk that is over, madam. We had
Oh,
some technical
goodness me.
glitches. Yeah, the second talk is starting now. Yeah.
Okay, okay.
So over to Dr.
Okay.
Sarita, madam.
Okay.
Madam is online.
Yes, I'm hearing.
Yeah.
Hello, hello.
Welcome to Kasoga,
Good evening,
madam.
everyone, and thank you, Kasoga. Thank you to the President, Dr. Durgadas Asrana, Dr. Shobha Guri, and Dr. Rupesh for this invitation. Yeah,
Yeah,
that's fine then. I'll just start sharing my screen.
So Madam is currently, just briefly before you start, Madam.
Yeah.
Madam is, the chairperson for the Gynecological Oncology Committee of FOXY. And she's a very dynamic person who has been very active in carrying out lots of activities for the FOXY. Madam, over to you.
Thank you.
I
for
think,
the nomination chapter.
Rupesh, if I may add, Savita has
Yes,
been, she has held important posts in ISCCP also. Isn't it, Savita?
Thank you. Yes, ma'am. I was the
Yeah.
president.
She was the president, and she
Yes.
has a lot of high profile work to her credit, including the introduction of the smart scope and conduct of conferences in Delhi. And she comes from a very, very vibrant society also, AOGD. So I think her work profile is very strong, and we welcome her to Kasoga. Rupesh, I
Yes,
was
madam.
just wanting to bring in that point of discussion which you had in the last talk. And I tend to agree with Bhagya that testing is now the norm, and all oncologists are asking for testing of at least some like IHC of the this thing, and then the polling mutation, etc., before planning for the treatment. Yeah. So I think, and students also need to know, because yesterday in our BSOG CME also we had a case on endometrial cancer, and the ESCO guidelines are very much being discussed. And I think all the upcoming gynecologists, they have to know about this. So it
Absolutely.
is, yeah. Thank you so much. Yeah, please start here.
Yeah, thank you. Thank you, Madam. Thank you, Dr. Shubha. So, yes, the staging has changed, and there's a lot of actually changes in the FIGO 2023 staging. But how does that reflect in management? Has the management changed accordingly? So the changes, and why this change has happened, because they found that even the apparently the low stage where the outcomes were poor. That is because of all these molecular factors, all these histological factors which indicated poor prognosis. So this is a brief recap about what the change from the 2009 to 2023 classification. Now, in stage 1, we took it as the tumor confined to the uterus, uterine corpus. And we divided that as stage 1A when there was less than 50% of myometrial invasion, and 1B when there was more than 50% myometrial invasion. Now in FIGO 2023, so it's not just the invasion of the myometrium, it's also the grade and the LVSI we have to take into consideration. So therefore, it is a combination of the histological type, the myometrial invasion, and the presence or absence of LVSI, that is lymph vascular space invasion. This is seen by the pathologist. So basically, you see tumor cells in the vessels. So if you find that, that means it indicates an aggressive tumor, or tumor which is more likely to spread to the lymph nodes. Now, if it is categorized as 1A or 1B, now as FIGO 2009 now applies only to the non-aggressive histological types with no or focal LVSI. So for non-aggressive histological types, when there is no no LVSI, then that introduces, now there is stage 1A1, when there is nothing, it's just confined to the endometrium. There is no invasion of the myometrium. So that is stage 1A1. But when it goes into the myometrium, it's less than 50%, then it is stage 1A2. I'll just use the pointer. And if it is more than 50% myometrium, then in myometrial invasion, it is 1B. But it is all non-aggressive histological type, or the low grade, or the endometrioid and adenocarcinoma. For aggressive histological types, that means anything other than endometrioid. So if it is serous carcinoma, clear cell, whatever, so all that becomes aggressive. So that becomes stage 1C. So aggressive histological type without even there is no myometrial invasion, it will still become 1C, and considers any myometrial invasion as 2C. So if there is any myometrial invasion, it becomes 2C. Now, there is a category here introduced that in stage 1, when there is ovarian involvement. Also, it is considered in stage 1 if the following criteria, that is, it is low grade, there is no myometrial invasion, no or superficial myometrial invasion, there is no LVSI, and there are no additional metastasis, and this ovarian tumor is unilateral, confined to the ovary without capsule invasion or rupture. So when there is a tumor in the ovary, but it's a low-grade tumor, there is no invasion, there is no LVSI, it is still considered in stage 1. So this is about stage 1. Now, what about stage 2? Now, stage 2, 2009 classification, we defined it as when there was invasion into the cervical stromal tissue. But now, what is stage 2? So it is a combination of cervical stromal involvement, LVSI, and aggressive histological type with myometrial invasion. So now stage 2. Stage 2 is now subdivided into 2A when there is cervical stromal invasion by non-aggressive. Can you actually just mute the others, please? The organizers. So stage 2 is subdivided into 2A when there is cervical stromal invasion by non-aggressive histological types, or when there is, if it is 2B, when there is LVSI, but it's a non-aggressive histological type, and 2C when it is aggressive histological type with any myometrial invasion, it becomes 2C. It is a bit confusing. So whenever you get a case, you need to actually look up, go back to the staging and see where the patient comes into, which category she falls in. Now, coming to stage 3, so it is defined as in 2009 when there was spread outside the uterus other than the bladder intestines. So here we divided it as 3A, 3B, and 3C. When there is 3A, when there was tubo-ovarian and serosal involvement, and 3B when there was vaginal or parametrial tuber involvement, and when there was metastasis in the lymph nodes, pelvic and parotid, that was 3C. So this was a 2009 classification. So what is now the 2023 classification? Now 3A is subdivided into 3A1 when it is spread to the ovary or the fallopian tube, and 3A2 when there is involvement of the uterine subserosa or spread through the serosa. So there is a concept of subserosa also included. That is, it is just short of this serosa. Now 3B, now coming to 3B, it also includes the pelvic peritoneum, and it is subdivided into 3B1 when there is metastasis or direct spread to the vagina or parametrium, and 3B when there is metastasis to the pelvic peritoneum. And then 3C1 is spread to the pelvic lymph nodes. Now it is subdivided into 3C1 micrometastasis, 3C11 that is micrometastasis, and 3C12 that is when there are macrometastasis. So this is, but 3C1 is just confined to the pelvis. But when it is if it's spread to the parotid lymph nodes, it becomes 3C2, and it is subdivided into 3C21 when there is micrometastasis, and 3C2 when there is macrometastasis. Now, stage 4, again, it groups, in 2009, it was abdominal peritoneal spread, along with spread to the lungs, liver, bones, so distant metastasis, and extrapelvic lymph nodes. So that was stage 4B. So now here 4B is subdivided into 4B and 4C. So 4B is spread inguinal or when there is abdominal peritoneal spread, it is now 4B, but when there is lung involvement spread to the lungs, liver, brain, bone, inguinal or extrapelvic lymph nodes, then it becomes stage 4C. Now, how is the management different based on the staging? Now, the ESGO, that is the European Society of Gynecologist, brought out guidelines for the management of patients with endometrial carcinoma. And so the general recommendations all these are grade A recommendations. So planning and staging should be on a multidisciplinary basis. So generally at a tumor board meeting. So when you have a case, discuss it with your pathologist, discuss it with your radiation oncologist and medical oncologist and radiologist. So according to the local guidelines and based on comprehensive and precise knowledge of the prognostic and predictive factors for the outcome. And then patients should be carefully counseled about the suggested diagnostic and treatment plan and potential alternatives, including risks and benefits of all the options. And treatment should be done at a specialized center, preferably by a dedicated team of specialists who are in the diagnosis and management of gynecological cancers. So it's important now. Endometrial carcinoma is associated with Lynch syndrome. So it's important to identify whether your patient is coming under the has a Lynch syndrome, has a gene which is the Lynch syndrome. So how to identify them? So how do you identify? That is, if you do the MMR IHC, that is, if you have MMR deficient, so that is how you can diagnose. You can suspect that this could be a Lynch syndrome, and then we go for the genetic analysis and genetic counseling. So definition of prognostic groups, integrating the tumor markers, and this is a grade B recommendation. So histological type, grade, biometrical invasion, and LVSI should be recorded in all patients. As Madam said, all patients with endometrial carcinoma, all these things you should get the report. So if you get a report from your pathologist saying that only adenocarcinoma of the endometrium, you should go back and ask them, that is, give me all this information, because all this information is important to plan the management. So what is the risk? How is the risk? How are they classified? So it is low risk if it is stage 1 and endometrioid, and it is well differentiated, grade 1 or 2, and there is less than 50% invasion, less than 50% biometrical invasion, and there is no LVS. Basically, it's a good prognosis tumor with less than 50% invasion. That is low risk. Intermediate risk when it is stage 1, again endometrioid, grade 1 or 2, but there is invasion of more than 50% of biometrical. So that becomes intermediate risk. Whereas high intermediate risk is whenever it is still stage 1, less than 50% biometrical invasion, regardless of LVSI. But if it is grade 3, that is, it's an undifferentiated tumor, or there is lymph vascular space invasion, again, it becomes high intermediate risk. So you see, the pathology is so important in planning the management and for the prognosis. Again, it becomes high risk when it is stage 3, even if it is stage 1. But if it is grade 3 and more than 50% biometrical invasion, regardless of LVSI, or it is stage 2 or stage 3, and it is a non-endometrioid, so it's a different histological type, non-endometrioid, again, it becomes high risk. And advanced, of course, we know that when it is already spread outside the uterus, so that becomes advanced. So it's so important to actually get the entire information from your pathologist when you get the diagnosis of endometrial carcinoma on the biopsy. So the low risk, if you know the molecular classification, then that is well and good. That is pole mutated. It becomes low risk. So even if it is stage 1 or 2, but it is pole mutated, it becomes a low risk. Okay, whereas if you did not know it, she becomes, you put her in stage 1A, endometrioid, low grade, LVSI negative. Again, it is still low risk, but this is only applicable to stage 1A if you don't know the molecular classification. But if you do the molecular classification in stage 1 and stage 2, and you find pole mutation positive, then she becomes low risk. Now, what is intermediate risk? Now, how the difference, now, as we already discussed, molecular classification is unknown, but stage 1B endometrioid, low grade, stage 1A endometrioid, but high grade, stage 1A non-endometrioid, that is any other type of tumors, all this becomes intermediate risk. But if you knew the molecular classification, then in that case, so stage 1B, MMR deficient, also comes under intermediate, even if it's low grade and LVSI negative. And stage 1A and MMR deficient, but it is high grade, again, it becomes intermediate risk. And stage 1A, but P53 abnormal. But so it's confined to the endometrium, but P53 abnormal, that is going to advance it's going to worsen the prognosis, so it becomes intermediate risk. And a histological type, anything other than endometrioid, again, it becomes intermediate risk. Now, high intermediate risk is when, again, if you did have the molecular classification, if it's stage 1, but it is MMR deficient or NSMP, that is non-specific molecular profile, but there is substantial LVSI, and this regardless of the grade and the depth of invasion. So if there is definite LVSI and it is MMR deficient, or it is stage 1B, again MMR deficient, and it is high grade, again, it becomes high intermediate risk. Or stage 2 MMRD, MMR deficient endometrioid. If it's endometrioid but stage 2 and MMR deficient, again becomes high intermediate risk. Whereas high risk, anything which is P53 positive, that is, it is not just positive, it's not wild type, but it is a mutant that is completely, it is filling up the report comes as P53 mutant. So that is what is abnormal. So it's important to actually find out, what is the degree of P53 abnormality. So if that is P53 abnormal, then it becomes high risk. So any patient, if it's coming as, even if it's early stage, even stage 1 to 4A, P53 abnormal. So it becomes with any myometrial invasion and with no residual disease. So again, it becomes high risk. And advanced is anyway, it is stage 3 and 4A and or 4B. So if you did have the molecular classification, or if you had the histology, if you had some IHC information about IHC, you can classify your patients as per the risk, the low, intermediate, or high risk. So the molecular classification is encouraged for all endometrial carcinomas, especially the high-grade tumors. Pole mutation can be omitted actually in low risk and intermediate risk with low grade histology, because it's not going to change much. Your management is not going to change much in the low risk and the intermediate risk with the low grade histology. So it's ideal to do the pole sequencing first for the molecular analysis, and then if it is polymutant, it becomes a good prognosis. And if there is no mutation, so then we go for MMR IHC. And if there is MMR, if it's MMR deficient, then it becomes, this is the category. And if it's NSMP P53 abnormal, P53 normal, it is an NSMP, and P53 abnormal, P53 aberrant. So then we can classify it accordingly. However, it does not follow, because we generally get the immunohistochemistry results even before the the molecular analysis. So we get some information before, and the pole usually takes time. Now coming to the preoperative workup. So what's important is, as I said, the histological tumor grade and the type and the grade of the tumor is important in the endometrial biopsy. So if you don't get that information, so the tissue is insufficient, then you may have to repeat the DNC. And then preoperative mandatory workup, family history, general assessment, and look for comorbidities, because this is common in patients who are generally they are diabetic, hypertensive, and the geriatric assessment if appropriate, clinical examination, including pelvic examination, expert transvaginal or transrectal ultrasound or pelvic MRI. So depending on the clinical and pathological risk, additional imaging modalities, that is, so pelvic MRI, definitely it is indicated, and to look for metastasis in other parts like the thoracic and abdominal, CT scan is needed, or even ultrasound actually, to know whether there are any metastasis in the liver, and to assess the ovaries, the nodes, the peritoneum, and other sites of metastatic disease. So you will get to know about the lymph nodes, the pelvic lymph nodes in the MRI also. The intraoperative frozen section is not encouraged for myometrial invasion because it is not reproducible and it can interfere with adequate pathological processing. So before you go for the surgery, it's important to discuss with the radiologist and the pathologist. So radiologist about the degree of myometrial invasion and whether there is any involvement of the lymph nodes and other metastases. So in early stage disease, if it's stage 1 and 2, minimally invasive approach is the preferred surgical approach, because these women are generally obese, and including those patients with high risk endometrial carcinoma. But you must avoid any intraperitoneal tumor spillage, tumor rupture, or morcellation, including in the bag, should be avoided. And if vaginal extraction risks uterine rupture, other measures should be taken. So if you cannot deliver the uterus from below, you can use a mini laparotomy or use an endobag. And then tumors with metastasis outside the uterus and cervix, excluding lymph node metastasis, they are relative contraindications to minimal invasive. So basically, if it's spread beyond the uterus and the cervix, then it's better not to go for minimally invasive surgery. The standard surgical procedure is total hysterectomy and bilateral salpingoophorectomy. There is no need of taking a vaginal cuff. Now, infracolic omentectomy should be performed in stage 1 if it is it's basically serous endometrial carcinoma, carcinosarcoma, and undifferentiated carcinomas. So it can be omitted in clear cell and endometrioid carcinoma in stage 1 disease. Now, if patient has been operated outside and she comes with a report, so she had a hysterectomy outside, and the report says that's endometrial carcinoma, should you go for restaging? Suppose it is a high intermediate risk or high risk, so that is based on the pathology. So then you may have to go for restaging because it will have an implication on the adjuvant treatment. That's why it's very important. Actually, we have patients coming back. They had hysterectomy for atypical hyperplasia of the endometrium, and the final histology comes as endometrial carcinoma. So, they only had a TH, BSO. So it's very important to actually review the pathology, the histology with the pathologist before you plan the surgery. So in stage 1 endometrial carcinoma, surgery, that is a hysterectomy, bilateral salpingo-oophorectomy, yes. Then if it is grade 1 and grade 2, stage 1A, that is just confined to the endometrium, ovarian preservation is also possible in young women. Now, if it is it's stage 1 and grade 3, or you can go for minimally invasive surgery, sentinel lymph node can be considered as a strategy for lymph node assessment. So, instead of a complete lymphadenectomy, only the positive. So, there is basically a dye is injected, and to see if there is uptake in the lymph nodes. So, if there is uptake in the lymph nodes, only those lymph nodes are taken out. So that is considered as a positive node, and that is sent for ultra staging or further final histopathology. So that is called a sentinel lymph node. Now, if it is stage 1A, but if it's serous endometrial carcinoma or carcinosarcomas, you need to include omentectomy, peritoneal biopsies, and lymph node staging. So it has to be a complete surgery. Now, coming to the lymph node assessment, the risk of lymph node involvement, it varies between less than 5% to 40%, depending on the grade, myometrial invasion, and histology. So it can be omitted actually in endometrioid grade 1 to 2 disease because the risk of nodal metastasis is very low. That is less than 5%. But you will have all this information. That's only if you have the entire information before you plan the surgery. So the evaluation of lymph node status is recommended in patients even with non-endometrioid histology. You must go for the lymph node status if it's FIGO 1B or grade 3 disease. So lymphadenectomy has to be performed. Now, evaluation, what is sentinel lymph node? Now, there is, apart from the evaluation, retroperitoneal serosal evaluation and washing. So when you go for retroperitoneal evaluation, that is the pelvic and paraortic lymph nodes. So if you find that sentinel lymph nodes, there's take up of the dye, then take out all those involved lymph nodes with ultra staging and any suspicious nodes. So even if they don't take up the dye, but you find that low nodes are enlarged, those should also be removed regardless of the mapping. But suppose there is no the dye is not taken up at all, then that side the lymph node dissection should be performed, and the paraortic lymph node dissection. That is depending on the attending. This is as per the NCCN guideline. But if you find that if it is a high risk, definitely it is indicated. Now, is radical hysterectomy indicated? So this is earlier we used to do radical hysterectomy if there was involvement of the cervix. So what is the consensus now? So it is total hysterectomy with bilateral salpingo-oophorectomy and lymph node staging. This is the standard of care in stage 2 endometrial carcinoma, and more extensive procedures only if you have to achieve free surgical margin. So typically the taking the entire parametrium is not needed, but it's as long as you can take a free margin, that's important. So medically unfit patients have the medical contraindications to the standard surgical management by minimally invasive approach are rare, but you can go for vaginal hysterectomy if the patient is very high risk and generally it is not possible to give a general anesthesia, then it can be done in some of the patients, selected patients. Now coming to adjuvant therapy in early stage 1 and 2. Then stage 1 to 4A, adjuvant therapy for low and intermediate risk. So if it's low risk, stage 1A, that is just confined to the endometrium, and grade 1 and 2, with MMR deficient or an SMP, and there is no or focal LVSI, then it is not recommended. Adjuvant therapy is not recommended. And those with stage 1 and 2 that are polymutated, again, you can omit adjuvant therapy. But if they're intermediate risk, that is, if there is stage 1, if it's high-grade tumor, MMR deficient, then you, or if it's stage 1B and grade 1 to 2. So again, the adjuvant brachytherapy, that is vaginal brachytherapy, is recommended. And also for stage 2, grade 1, so well differentiated, but stage 1. So these are some, although it is a early stage, but since it is intermediate risk, in those cases, vaginal brachytherapy is recommended. Now coming to the low risk, so this is about the low risk disease, low risk endometrial carcinoma. So no adjuvant therapy is recommended, but when molecular classification is known, stage 1 to 2 low risk based on pathogenic pole mutation, omission of adjuvant treatment should be considered. So if you know pole is mutant, then you can omit adjuvant therapy. But all these molecular tests should be done in a standard validated lab, and not any lab should be doing this, because you can have a false positive report. I mean, a falsely positive saying that pole mutation. So do get it done in a standard lab. For rare patients with endometrial carcinoma, stage 3 and 4 and pathogenic pole mutation, there is no, now this is what I was saying, that right now the guidelines do not say do not give adjuvant therapy. So there is still, the studies are going on, data is being collected. The FIGO has not made clear recommendations about omission of adjuvant treatment in this stage 3 and stage 4A. And they are encouraging registration for this. Now, when there is high intermediate risk, there is no lymph node involvement after lymph node staging, adjuvant brachytherapy can be recommended to decrease the vaginal recurrence rate. And external beam radiotherapy can be considered when there's substantial LVSI, there's lymphovascular space invasion, and for stage 2. Now, adjuvant chemotherapy, if it is high grade or there is LVSI, in that case, chemotherapy is also given. And omission of adjuvant treatment is also an option even there is this pole mutation is known. And they actually have specific recommendations. And again, this has to be in consultation with it has to be in a multidisciplinary tumor board, and discussion with the patient is also important. So high intermediate risk, adjuvant brachytherapy, external beam radiotherapy is recommended, especially for substantial LVSI or for stage 2. And additional adjuvant chemotherapy also can be considered, especially for the high grade and substantial LVSI. And adjuvant brachytherapy alone can be considered for the high grade LVSI negative and for stage 2 grade 1 endometrioid carcinomas. Now, high risk, it is both. It's a combination of external beam radiotherapy and chemotherapy, or alternatively, sequential chemotherapy and radiotherapy is recommended. Chemotherapy alone is also an alternative option. And carcinosarcoma should be treated as high-risk carcinomas. They are high-risk carcinomas and not sarcomas. And so this is the NCCN guideline based on, again, they have not clearly, that this is the American guidelines. Now they are, the recommendation for stage 1A, grade 1 to 2 is observation is preferred. And vaginal brachytherapy if the lymphovascular space invasion is there or the age is more than 60 years. But if it's a high grade, again, vaginal brachytherapy is preferred, and consider observation if there is no myoinvasion, and consider EBRT if the patient is elderly, more than 70 years, or there is LVSI. Now it's stage 1B, if it's grade 1, vaginal brachytherapy is to be considered. And with grade 2, again, vaginal brachytherapy and EBRT if the patient is more than 60 years. And grade 3, it's again radiotherapy, external beam radiotherapy plus or minus systemic therapy. That is for stage 1B. Whereas stage 2, if it's grade, whatever the grade 1 through 2, external beam radiotherapy is preferred, plus or minus vaginal brachytherapy, plus or minus systemic therapy. Now coming to advanced disease, as stage 3 and 4. Now in advanced disease, stage 3 and 4 endometrial carcinomas, including carcinosarcomas, try and do as much tumor bulking as possible, including the enlarged lymph nodes should be considered, and complete, if possible, if you can go for a complete macroscopic resection with acceptable morbidity and quality of life profile following a full pre-op staging and discussion in the multidisciplinary team. And primary systemic therapy can be used if upfront surgery is not feasible or acceptable. That is primary sort of neoadjuvant chemotherapy. It can be can be done. So in case of good response to systemic therapy, delayed surgery can be considered. And only enlarged lymph nodes should be resected. You need not go for a complete lymphadenectomy. So this is the NCCN guidelines for stage 3 and stage 4. If it's once surgically staged, one must go for systemic therapy. This is chemotherapy plus external beam radiotherapy and plus or minus vaginal brachytherapy. Now, does really all this modified staging, is it going to really help the management? So there were actually a retrospective analysis of all these endometrial carcinomas patients who were staged with the molecular characterization. And so they were categorized according to FIGO, both FIGO 2009 and 2023. So what they found, there was a stage shift. So you see that a lot of patients are actually going into higher stages. So about 27.6%, majority were upstaged. And upstaging was endometrial carcinomas with aggressive types with any myometrial invasion are classified in the FIGO 2023 as stage 2C. And the new FIGO classification resulted in a higher prognostic precision compared to the former one. And those patients with 2C had a similar 5-year progression-free survival as other stage 2 patients as the FIGO's 2023 staging system. So this actually helped in deciding, actually giving a precise, better prognostic precision for the patients. So there was excellent prognosis when there was pole mutation is positive. It's 100% 5-year progression-free survival and unfavorable. But if it's P53 abnormal, then the prognosis is unfavorable. So you can see it drops down to just 60%. So validation for advanced disease. So the Matzo et al. Compared the FIGO 2009 and 23 staging systems in more than 5,000 patients with advanced stage disease. This is in the SEER program, and the 5-year endometrial cancer specific mortality rate, the new downstage, so the A1A3 group, that is low risk, those who have ovarian metastasis, was only 11%. And this was much lower than the new 3A1 group. So whereas the 3A1, when that was actually spread to the ovary or the fallopian tubes. So basically the mortality rate differed in the stage, in the 1A3 group and the 3A1 group. So this isolated metastasis in the ovary actually gives a better prognosis. So those with macrometastasis in the lymph nodes had higher endometrial cancer-specific mortality than those with micrometastasis. So that means those with micrometastasis had a better prognosis than those with macrometastasis. So there are criticisms of this new FIGO staging. So is it really too much too soon? It's complicated. For all of us, it's difficult to compare with the old FIGO patient classification in the trials, patients who have already been recruited to change to this FIGO staging. It's difficult. Pathological variables are still evolving. Again, superficial myoinvasion is difficult to identify because there is very poor inter-observer agreement. This involvement of uterine subserosa, there is that category has been defined, but it's not clearly defined. And the LVSI, again, there are various definitions by pathological organizations. And molecular testing, again, there's, as Madam was saying about the cost and availability. Again, smaller centers, they may not have these labs to actually do it. And it's difficult to apply globally. And pole mutation, again, there's, as I said, it's a varying reporting happens. And it may confuse patients and clinicians because the state change pre-op. So pre-op, there is one stage, and post-op, the state changes with the molecular analysis. So basically, it's a new FIGO staging. It has to be a personalized manner. So every case is individualized based on the discussion with the pathologist, the radiologist, and the patient. The typing, the grade, the LVSI has to be reported in all. the immunohistochemistry, that is ER/PR, P53, and MMR IHC. This is very important. Try to get this information for all the from the pathologist, and molecular markers are useful in the high-risk patients. So thank you so much for your patient listening.
Thank you so much, madam. This was indeed such a comprehensive, and it's always a very difficult task to, present the management aspects in endometrial cancer, because, as you very well said, that it is confusing. It is not easy for us to remember each and everything of these things as clinicians.
Yes.
But one good thing is that futuristically, these are the subset cohorts wherein we will get to know like what is beneficial in which subcategory, and that is when we will be having newer guidelines down the line. So, but till then, I'm sure that it's always very good. We should make it a practice to classify everything according to the latest classification what Dr. Sarita madam has shown. That was an excellent presentation, madam, and I'm sure like one good thing is that the ESGO has made guides. There are ESGO guides, so that's what we follow. Especially I follow the same, wherein you can there are particular drop down boxes which you click and you get to know. It gives us the risk stratification, because there are so many different types of risks: the low risk, the low intermediate risk, high intermediate risk, and all these stuff. So all these things are made very make it easy. The ESGO guides are there. So yes, as GYN oncologists, we often resort to those things, and of course we ask the help of our radiation oncologists and medical oncologists. I'm sure Dr. Ajay and Dr. Santosh are waiting with a bated breath for the panel discussion. So it's a great presentation. Thank you so much, madam. In the uh, wherein at the outset, wherein due to the time constraint, if we can have questions by messages, will be
Yeah,
grateful, and so that
Rupesh,
we can start the panel discussion.
just one thing which I wanted to appreciate about this presentation.
Yes, ma'am.
Of course, scientifically it was amazing and very complete, and we don't expect anything less from Sarita actually.
Thank you, madam.
Being the
Definitely.
perfectionist that she is. One thing which I really liked about her presentation is she said when you get a case, go back to the FIGO staging and refer it. That is wonderful, because see, it is good to open up the staging now and see, because it has become so complex today.
No,
So I
it is very
really
intricate,
liked
madam.
that.
Yes.
I really liked that. So never feel that, it is some kind of ignorance not to know it by heart. So I think from now on, I'll start telling the PGs that whenever you get a case, you see the staging and then you kind of go ahead.
Yes.
Even
Absolutely,
in, I
absolutely.
think even examiners should not expect PGs to know it by heart.
It's
The
very difficult
examiners
to
also,
remember.
it's
It
so
has become
difficult for
that
the
complex.
examiners to remember also.
Yes.
That's what I'm
Yeah,
trying
yeah.
to say.
I think
That
everybody
is
will carry
difficult now
guides,
for
madam.
everybody. So everybody should have a reference kind of thing for this.
Absolutely,
So
absolutely.
it's a good message to give. Thank you so much, Sarita.
Definitely. Thank you so much, madam. Thank
There
you.
is
So,
there is one question about they're asking whether atypical hyperplasia should go for molecular markers. No, it's only for the malignancy. If you get a diagnosis of malignancy, only then. So it's atypical hyperplasia. You get it reviewed by the pathologist, because there could be an association with endometrial carcinoma. So there could be endometrial carcinoma in the other the rest of this. Maybe one focus you've got atypical hyperplasia. There could be another focus where there could be malignancy. So it's important to get the entire thing reviewed. So make sure that if you get it as endometrial carcinoma, then in that case, molecular markers, molecular testing is indicated.
yeah,
Madam,
totally.
when you recommend if somebody is having recurrent vault recurrence of only single polypoid, one single polyp is recurring from the vault, and there is no any metastasis any other part of the body after after the surgery of say endometrium.
Could you be more precise, Prabha,
Yeah,
madam?
see, there is
Like,
one case which has been operated 2 years back, and she develops only a single polyp in the vault. Okay, and that turned out to be a adenocarcinomatous polyp. Two times we have excised it is, and it is hardly 1 by 1 centimeter kind of thing. But her PET scan and all is normal. And I, frankly speaking, we have not done her molecular study of that.
Ma'am, the most important thing here is first we will need to know the previous surgery details in terms of the histopathology, wherein like what
It
was the
was
grade,
endometrioid adenocarcinoma of
grade of the
the,
disease.
yeah,
Was it
grade
1A?
was 111, grade 1A.
It's a grade 1. And was it like laparoscopic surgery? Like if yes,
No,
like
it was
how?
open surgery. It was open
Okay.
surgery.
Lymph nodes addressed that time. So there are
Yeah,
multiple
yeah,
aspects that we need to know.
everything has been done, and it was turned out to be stage 1A1.
Okay, 1A1. So, okay, in that case, again,
So
maybe
there is, it is metastasis to the, I mean, it's a recurrence in the vaginal wall. So it has to
Yeah.
be treated as a recurrence.
And the same site, it will come only one polyp kind of thing.
ma'am,
So that's
generally
fine,
post
but recurrence is a recurrence only.
yeah,
Yeah.
generally in endometrial carcinoma, once the primary surgery has happened and once they recur, of course, it's imperative to get the biopsy and all the IHC markers as well as the mutational analysis if possible. And generally, post-surgery recurrences are treated by radiation. So, we need to have a multidisciplinary tumor board discussion, as I told, with the medical and the radiation oncologist, and together review the
No
imaging.
role of
Review the
chemotherapy.
imaging. Yeah, review the
Any
imaging and take into consideration. She will have to be treated with the multi-pronged approach. Like if she's operable, yes, maybe we need to
No,
take
there
a
is
call
only
on that.
one polyp. It will comes out once you put it on the Alice. It comes out, and again after 6 months, you will get one more polypoid thing growth.
So
At the
if she hasn't
same.
undergone radiation, I would suggest radiation, madam. So,
Okay.
maybe on an individual basis, we'll have to.
So, hello, hi. So just one
Yeah.
point that
Yes, Dr. Ajay.
going forward, yes, you have to do external radiation and brachytherapy to this patient. And adding chemo is like, because it's a recurrent tumor, so it's individualized. We can always give concurrent chemos and as an extra thing. But yes, going forward, this polyp after the excision which you have made has to go for a complete external radiation and brachytherapy. And if the lymph nodes have been addressed before, then there is no ideal need for treating the lymph nodes, but the vault region, which has to cover a proper 2 centimeter inside and outside, and it has to go for around 45 to 50 gray, followed by brachytherapy. So that is the treatment going forward.
Yeah. So great. So I'm sure that, Prabha madam, that we need to give radiation is the answer, along with plus or minus chemotherapy. So we'll move ahead towards the panel discussion. We have three interesting cases. Of course, the first one is a simple case. Dr. Prerna, over to you. Could you please share your screen with the cases for the panel? And before that, kindly introduce our esteemed panelists today. And then, yeah.
Rupesh, it is not necessary only polypid growth only to be given radiation. Even otherwise also, say serous carcinoma and all, that vault is being treated by the brachytherapy.
Definitely, madam. Yeah, we were
It is
just
a
Dr. Prabha
rather
madam
a
asked.
part of the management would be that.
Ma'am, best
Apart
is
from
you send the case to
your
me, madam. I'll manage it,
surgery
madam.
as well as chemo or brachytherapy.
There are clear-cut guidelines, madam. So, I mean, as a GYN oncologist, that's what we do. So, if you have any doubt, please let me know, madam. I'll
No, I think that somebody was discussing about polyp, no? That would require the brachytherapy. Even if there is no polyp, even if there is no recurrence, it is better to give to the vault of vagina the brachytherapy.
There are indications for that, madam. We will discuss in the coming slides. Maybe in the panel discussions, we have a couple of interesting ones. So, Dr. Prerna, yes, please go ahead with.
Thank you, sir. So moving on to the panel discussion today, let me introduce the subject experts for today's discussion. We'll start off with Dr. Shobha Gudi ma'am. Madam's name is famous in the BSOG and Kasoga. Currently, Madam is the Secretary General of Kasoga. She's Professor and HOD at St. Philomena's Hospital, Bangalore. Madam is a passionate postgraduate teacher and examiner, and she's part of the DNB program. She's had multiple publications, and she's authored a book on obstetric hemorrhage. Moving on. Next. Our next expert is Dr. Bhagyalakshmi Nayak. She is the professor in the Department of Gynecologic Oncology at Acharya Harihar PG Institute of Cancer, Cuttack. She is also the chairperson of Oncology Committee, FOXY, and a governing council member of ICOG. She's held multiple posts. She's a peer reviewer in the Indian Journal of Surgical Oncology, and she's received many national and international awards. Next. Our next speaker is Dr. Aparna Ganguly ma'am, who is a lead oncopathologist and founder at Phoenix Oncopathology. We are already familiar with madam. Next subject expert is Dr. Rupesh, who is a senior consultant and gyneco-oncosurgeon, peritoneal oncology specialist, and laparoscopic and robotic surgeon in Bangalore. He is also the chairperson of Gyneco-Oncology and Preventive Oncology Committee, Kasoga. Our next subject expert is Dr. Santosh Kumar Devdas. He is the professor and HOD of Department of Medical Oncology at MS Ramaya Cancer Center. He has received multiple awards for his research activities, including reputed European Society of Medical Oncology, and also he has received the Accord Fellowship. He has multiple publications in reputed national and international journals and has presented papers and delivered faculty lectures at various forums. Our next speaker is Dr. Ajay Rao, who is a senior consultant and radiation oncologist at Fortis Hospital, Banerghatta Road. He's assistant professor in Department of Clinical Oncology at Dr. Chandrama Dayanand Sagar Institute of Medical Sciences. He's been trained in Europe for specialized procedures like IMRT and VMAT, and he's participated in many clinical trials. He's an active faculty in over 130 national conferences and 7 international conferences. He has conducted many free camps as well. So without further ado, I'll start the panel discussion. Let me share the screen. Is it visible?
Yes, it is visible, Dr. Prerna. Could you please put it on the slideshow? I mean, if in case. Yeah, great.
So we'll start off with the first case. Our patient is Mrs. D, 74 years old. She came with postmenopausal bleeding for 2 weeks. She had attained menopause 24 years ago. She was obese, diabetic, and hypertensive. On examination, there was bleeding through the os. On transvaginal ultrasound, endometrium was 8 millimeters thick. So the first question goes to Dr. Shobha Gudi ma'am. What would be your next step, ma'am? Hello? Hello?
Madam is okay. I mean, if I can just take that in the constraint of time. So definitely now, is she a postmenopausal lady, postmenopausal bleeding, thick endometrium and ultrasound. So definitely we would like to do an endometrial biopsy.
That's right. So between Pipple endometrial biopsy and hysteroscopic guided biopsy and dilatation and curettage, which would you choose?
Madam is there, Dr. Shobha Gudi, madam. Yep. So it depends. Like since Pipple endometrial biopsy has a good sensitivity, I mean decent sensitivity. If that's available in thick endometrium, it's wise to do. But sometimes in postmenopausal bleeding with thin endometrium, sometimes maybe I would prefer to do hysteroscopic biopsy. But yes, a Pipple would do in this lady.
So that's right. So in Pipple endometrial biopsy, the sensitivity is as high as 97% and specificity over 90%. We would go for hysteroscopic guided biopsy if there is a chance of poor yield where the ET is non-uniform.
Exactly. Yeah.
Moving on to the next question. This is to Dr. Aparna ma'am. Ma'am, what are the mandatory parameters to be reported in an endometrial biopsy?
Sorry, I'm so sorry. Was there any problem from my side?
Ma'am, you are not audible. I don't know, maybe you were muted. Yeah.
Okay. I think there was some problem. Okay, I'll follow it now. I'll follow it. Thank you.
Sure, ma'am. Sure, ma'am.
Over to you, ma'am. Aparna ma'am.
Yeah. So we need to firstly see the thickness less than 50% or more than 50% of myometrial thickness, invasion of myometrial thickness.
No, this
Okay.
is on the, I'm so
This is
sorry to
on
interrupt.
endometrial biopsy, ma'am.
This is on the,
This
This is
pipal
on the
biopsy.
curettage.
Yeah,
On the-
curettage or
on the endometrial biopsy.
yeah,
Pre-op.
curettage or a
Pre-op.
pipal biopsy.
Yes.
Pre-op.
Right.
Mandatory parameters, we would have to grade it.
Yeah.
First thing is grading. Secondly, we'll have to confirm whether this is atypical endometrial hyperplasia or invasive. There are definite, we follow what is known as Kurman-Norris criteria to differentiate between atypical hyperplasia and endometrial carcinoma. Okay, we'll have to put the parameters of that Kurman-Norris there. And once we confirm that it's a carcinoma, then we will have to grade it, whether it is grade 1, grade 2, grade 3, then whether it is endometrioid or whether it is serous or whether it is clear cell. At this point, IHC may be called for. IHC may be called for to confirm, firstly, to confirm serous. Secondly, to distinguish between serous and clear cell. We have markers like NAPCNA and WT1. This is the panel to differentiate between clear cell and serous. I think that's what we would primarily be looking at. Firstly, confirm that it's a carcinoma. Then what kind of carcinoma? And if it is endometrioid carcinoma, then what grade? But remember, the grading can get upgraded after hysterectomy, right? That has to be kept in mind. It may be well differentiated or grade 1, but then after hysterectomy, it may be grade 2. So that has to be taken with a pinch of salt.
Right, ma'am.
LVFI if feasible, otherwise difficult.
Like
would you like to consider any IHC at this panel? Yes, I would like to consider, depending on the morphology.
Right.
Yes, we would consider, yes.
What panel would you consider, ma'am?
Again, depends on the purpose. What are we trying to do? Are we trying to confirm serous? If so, then P53 should be fine. Are we trying to differentiate between clear cell and serous? Then NAPCNA and WT1. Or are we going all the way and doing the complete endometrial prognostic panel? In that case, we will consider pole hypermutation, P53, as well as MMR.
Right. Moving on to the next question. This is to Dr. Bhagyalakshmi, ma'am. Which imaging modality would you choose? Ma'am, am I audible to you?
It's a transvaginal scan.
That's already been done, ma'am. TVS has already been done and ET was reported as 8 millimeter, after which we did the biopsy.
MRI?
Yes. We would go ahead with the contrast enhanced MRI of the pelvis with abdominal screening at least. We usually cover both the abdomen and pelvis, but we at least screen for the abdomen. So what would you look for specifically in the imaging?
Yeah, can I? Okay. Okay, you have asked Dr. B.
Ma'am, please go ahead, ma'am.
No. When you asked about, when you told about the endometrial pipple biopsy result, what it was, because I was out of connect at that time.
It was endometrioid adenocarcinoma, ma'am, grade 2.
Oh, endometrioid adenocarcinoma. Yeah. I think.
Bhagyalakshmi, madam, are you there?
I think MRI would be appropriate, right? To find out local invasive quantum of locally invasive disease. Maybe that is. I think CT is restricted for those cases where there is distant metastasis and more, organ involvement, and one wants to know the resectability, right, for prognostication. I think locally advanced disease can best assessed by MRI. Yeah, please.
Yeah. Shubha, ma'am. Yes, ma'am. Yeah. So in currently, there's very limited role of CT in gynecological malignancies. Most of the times we do MRI. And CT is mainly for, as you said, I mean, like extensive metastasis, especially in ovarian cancers. And, that too, when even there also MRI is the investigation of choice.
Okay.
But yes, yeah. For the next question, I think Bhagyalakshmi madam is not to be heard. Maybe she's on mute. Anyways, if I can take that question, what would you look for specifically in imaging? The very important thing about MRI is most of the gynecologists we ask for MRI pelvis with contrast. Sometimes that contrast also certain laboratories they don't. They just do an MRI plain. So no, it should be MRI with contrast, and it's not just the pelvis. Uh, at least up till the renal hilum, we have to cover because we also need to look for the up till the para-aortic nodes till the renal vessels. So that is our jurisdiction of surgery. So till there, it has to be seen. So when you ask for that, you ask for your radiologist till that. And next thing is what we see is, of course, we need to see, as Shobha madam told about the intrauterine characteristics of the tumor, like the size of the tumor, the myometrial invasion, if there's any cervical stromal invasion, if there is obvious ovarian involvement or whenever there's stromal invasion, that is, we also have to look for the parametrium and, of course, the lymph nodes. And in uh, in aggressive histologies, of course, the abdominal we have to see the momentum, presence of ascites, any peritoneal lesions. So this is how it goes.
Thank
Yeah.
you.
See,
Yeah, sorry, I
Rupesh,
have lost
Rupesh, it is
connection here.
good to, if I can have a word, huh? It is very good to list this kind of this need for imaging. It's very good. But then one thing which most gynecologists will puzzle over, that they will think that anyway a staging laparotomy is going to be done, and much of this mystery will be solved. So how exactly does MRI knowledge help in the surgery or in planning for the management?
Yeah.
That is what is more important, I feel,
Yes,
right?
madam. So if you saw Dr. Sarita madam's presentation, so there is so many risk stratification now that are involved, especially based on, for example, the surgical, what is the first is what is the surgery that has to be done? Next is what is the route of surgery? And next question is how do you address the lymph nodes? So these are the three essential things. So out of the first one, what is the surgery? Of course, a hysterectomy with a salpingo-oophorectomy is a norm. But yes, in certain women, can we preserve the ovaries is the question. In certain others, okay, how much of the lymph nodes to be addressed? Only SLN is enough, or you have to do a systematic lymph node dissection. The next thing is route of surgery, whether minimal invasive or so these are the three different aspects which are to be known by the surgeon before operating, and for that MRI gives us a great picture in terms of the myometrial invasion. That is one of the very important things, and of course the grade and the histology of the tumor is also something which gives us adequate information to plan for the surgery.
Yeah, Rupesh, just to add to what you have told, I think cervical involvement is the one very important thing which has to be addressed by MRI and Excel involvement. So I think these two will.
True, madam. True, madam. Madam came back. Thank you, madam. You were offline, and so I took your question. I'm so sorry. Yeah, please, Prerna. Yeah.
Okay. Moving on to the next question. Next scenario. Our patient, her endometrial biopsy turned out to be endometrioid adenocarcinoma, grade 2. On MRI, it was an inhomogeneous endometrial lesion infiltrating only the superficial endometrium with no breach of the endomyometrial junction with no adenopathy. So, clinically and radiologically, she was stage 1A1. So, our next question is to Dr. Bhagyalakshmi ma'am. Ma'am, what surgery would you plan for her?
So she's apparently stage 1A1, right? And
Yes.
she's grade 1, if I'm correct?
Grade 2, ma'am. Grade 2.
Madam, your voice was breaking. If you can kindly repeat. Your voice is breaking, madam.
Can you hear me now?
Yeah, you're better, madam, now.
Yeah. I think, yeah, she's grade 1 and stage 1. So do we have any, if there is a possibility of doing any molecular markers, I think I will do. Otherwise, I will plan her for a comprehensive surgical staging by minimal access surgery. So which will include, I think, a peritoneal washings. About the type of hysterectomy, there's still a little controversy about whether we should go ahead with hysterectomy or a type of hysterectomy. And sentinel, of course, as
Ma'am, we're very sorry, your voice is breaking consistently.
Rupesh, please go ahead, continue.
So sorry, madam, your voice was breaking. Yes, I mean, totally agree with you that we have to do at least a minimum extrafacial hysterectomy with bilateral salpingo-oophorectomy. And yes, for low risk cases, most now what is strongly recommended is the minimally invasive approach. And even for many of the high risk cases, depending upon the skill of the surgeon, but for low risk cases, it is minimally invasive. So yeah, and of course the sentinel lymph node detection.
So what would be the extent of surgery and on what basis would you decide? I think this is more related to the imaging question that was asked previously. This is in continuation.
Yeah, Dr. Bhagyalakshmi, madam. Yeah, I think there's an issue with.
Am I audible?
Yes, ma'am. Now you are. Please, ma'am, go ahead.
Okay. So I think since if we have done a very proper imaging and we have facilities for a sentinel node, maybe if you do the sentinel node, it would be enough. But like deciding not to do a lymphadenectomy in this case, what was the size of the growth apparently from the imaging?
8 millimeter, ma'am.
Was the endometrial thickness
8 millimeters. So taking into the Mayo criteria, if you see that it's a small growth, it's a grade 1, it's a no myometrial invasion, right? You told
Yes.
no myometrial invasion. So you may err on not doing a lymphadenectomy though, but then if you actually it would have been better if you had a molecular marker also with us, so that we are confident that it's a very low risk tumor and we can go ahead with a simple hysterectomy and bilateral salpingo-oophorectomy.
Right, ma'am.
Otherwise, I would err on doing a lymphadenectomy, at least a pelvic.
Right. So, next question is to Dr. Rupesh. So, what would be the mode of surgery? Would you choose?
As I said, she's a low risk category at least now without the molecular markers, whatever. So I would still do a minimally invasive because that's what we often do. So yes, I would like to do a minimal invasive surgery, whether lap or robotic, depending on the availability.
Yeah. Can I put in a word here, Rupesh? Conventionally, yeah. Can I?
Please, madam.
Yeah.
Please, madam.
Yeah, of course, that oncosurgeons are speaking and everything is going kind of well. I just wanted to bring in the perspective that will this not be surgical staging per se? Will it not be a staging procedure?
Yes, 100% staging has to be done.
Then I think we have to label the surgery as a staging laparotomy or a staging laparoscopy.
No, I mean,
not
initially
necessary?
that was the concept, madam. That was the concept.
Okay.
See, the thing is, what are you staging? It's surgical staging. See, unlike in ovarian cancer, where we stage by taking peritoneal biopsies and random. So that is what we do. Here, we are not worried about. We are only taking the lymph nodes out. So anyhow, you're addressing the lymph nodes. So that is the reason we do not mandatorily need to use the word staging for endometrial cancer surgeries. So only for high risk surgeries, for example, serous components, that is when, yes, you will have to take off, put in the scope and minimal invasive, have a look at the entire peritoneal surfaces as well. But for generally, we do not, the same concept of staging what we do for ovarian cancer is not applicable here. Because of the simple reason that you are anyhow addressing the lymph nodes and either through the sentinel. Yeah.
Okay. So are there particular indications, for lymphadenectomy? In all cases, you are not doing. There are particular indications for sentinel lymph node also, no?
Yeah,
to
generally
check
for
the
low risk
sentinel
cases,
lymph. Yeah.
yeah, generally for the low risk cases, we do sentinel lymph node. Low
Mm.
risk in the sense like it's like the grade 1, grade 2,
Mm.
less
Mm.
than half myometrial
Yes.
invasion.
Yes.
So these are the ones. And even in more than half myometrial invasion, grade 1, grade 2, we will be doing sentinel lymph node detection. But in high risk histologies, we
Now, when
generally
you
do.
are labeling as low risk, doesn't it mean that you would have done some kind of IHC criteria also? Some
Uh,
kind of genetic marker also, or no?
no, madam. No, I mean, even see, based on see the risk stratification now, classically
Because this
the
is sounding to me like the conventional risk,
yes, yes, yes,
stratification.
yeah,
Because this is what
preoperatively.
all these years we have been saying, that stage 1, grade 1 and grade 2, less than 50% myometrium is, a kind of low risk, right?
Yeah, true,
And
true, true. So,
lymphadenectomy need not be done. So conventionally, what we have been kind of following until at least a year back, and also teaching, is that some cases of endometrial cancer, early cases like this, can be managed with the by the gynecologist, because there are
uh,
very few instances where we can say that the gynecologist without an onco training can manage. But only endometrial cancer, early endometrial cancer, is perhaps the only gynec cancer where we can think of calling the oncologist only if necessary, like that. So am I wrong or am I right in this?
ma'am, I wouldn't say you're totally wrong, but definitely you're not totally right because
Mm.
the thing is, if I have to say, the ESGO has clear-cut guidelines like case-based clinical decision tool, wherein we have a like they clear-cut give us a prognostic risk group assessment, and even not just for the adjuvant treatment, but also for doing what should be done. I mean to say, like, he clear in the class in the guideline what they give poll, whether there is immuno the markers done or not. For that, based on that, there is a thing, and even if the markers are done, there is a thing. So there's a clear cut clinical decision tool, I repeat, from the ESGO clear cut endometrial cancer guide, wherein you get to know what is that. So only when it is truly proven from all angles that it is a low risk, and yes, not having a myometrial invasion, then maybe doing a simple hysterectomy by a gynecologist should suffice. But whenever there's a myometrial invasion, or when the risk stratification is moving higher up in the ladder, then that is when you should involve a gynecological oncologist. So there is a clear-cut clinical decision tool, which is very important, ma'am. I can share that later on the group. So that is something which we need to know.
Yeah, just to add, some cases actually we are not sure whether they'll need a lymphadenectomy or not. And on the OT table, sometimes decide to do a lymphadenectomy.
Yes, ma'am. The only thing is that, see, as a GYN oncologist, we keep encountering so many situations wherein the gynecologist would have done a good hysterectomy and with a bilateral salpingo-4ectomy, but then, you
Yeah.
end up, lymph nodes were not addressed. So now the question is to address the lymph nodes
So
or not. So
post-operatively, it becomes a grade
yeah,
2.
it's become
Yeah.
especially when you again have to do an imaging. You keep seeing enlarged nodes which may be reactive, or you do not know whether they are actually enlarged nodes due to the metastasis or because of the just a reactive node. So any day before embarking upon, yes, I can do this surgery, you need to go through a lot of, especially with Dr. Sarita madam's talk, we could get to know that there is so much of stratification, there's so much of knowledge that we need to have. That clinical case-based decision tool is something which is very important. And
Yeah.
after that, yes, we can plan for the surgery.
Yeah, Rupesh. So essentially, the surgical skill set is what
Yeah,
becomes important. So it's important to have a plan of care, very appropriate plan of care, because see, always it is the first surgery which matters the maximum for a
absolutely, absolutely,
cancer
absolutely,
patient. So that's the
absolutely,
message we should be giving out, because many
absolutely.
of them who have joined are gynecologists only. So nature has already, inflicted injury by giving cancer. So we must not add insult to injury, and we must do the most appropriate surgery the first time. That is the reason I brought in this discussion.
Absolutely, very important, ma'am, because
Yeah.
as you said, there has been that thing, but the important is knowledge of the the certifications. That is something which we need.
That is
ठीक है.
important. Yes.
Yeah, very nice.
Yes.
Moving on to the next question. This is to Dr. Rupesh. How would you address lymph node clearance in this patient, sir?
Yeah, so this lady is now 1A1, wherein the tumor is limited to the endometrium without any, you said there's no breach in the endomyometrial junction. So definitely radiologically, there's no myometrial invasion, but still many a times we also see that in the histopathology, there could be a 1 mm or 2 mm invasion later onwards. So I would like, as Dr. Bhagyalakshmi Madam earlier said that it's better to err on at least doing a central lymph node detection. So I would do a central lymph node at least.
You've answered both the questions, sir.
Yeah. So yeah, she can. I would still do a central lymph node. That should be enough.
In our patient, she underwent robotic type 1 radical hysterectomy with bilateral salpingo-oophorectomy and sentinel lymph node biopsy. The sentinel lymph node biopsy frozen section was reported as negative. So the next question is to Dr. Santosh. With this scenario, what would be the adjuvant therapy plan for her, sir?
Generally, typically we ask for a pole P53 and the MMR IHC. This looks like very early tumor, and unless we, for example, see a P53, in which case we may require some radiation. I don't think any additional adjuvant chemo or radiation is warranted. The radiation part, I think Dr. Ajay could address that.
Dr. Ajay?
So you have got the histopathology report now? Can I go back and see that?
1 second. As per the scenario that I have given till now, it's histopathology of our patient. Yeah. It was well differentiated endometrioid adenocarcinoma.
Okay.
It's limited to the endometrium. LVSI was negative. Stromal invasion was absent, so she was stage 1A1 as per the
She
histopathology.
can be clearly a low risk and no role for any adjuvant treatment at this juncture with radiation or chemotherapy. Yes. So that goes. So she can go in for observation.
Thank you.
But yes, yeah.
So this is the molecular classification and the risk stratification of endometrial cancer. It's already been discussed before. So this was a stage 1A low risk category disease. Let's move on to the next case scenario. Our second patient, Mrs. K, she was 32 years old, nulliparous. She came with irregular menstruation with dysmenorrhea for 4 months. She didn't have any positive family history. On transvaginal ultrasound, her endometrium was thick, measuring 15.7 millimeters. Biopsy showed grade 1 endometrioid adenocarcinoma. Imaging showed an irregular mass of 5.7 by 2.6 by 2.1 centimeters. Along the posterior aspect of the myometrium with diffusion restriction, there was indistinct endomyometrial junction in the posterior aspect with less than 50% myoinvasion on the imaging. MRI did not show any cervical stromal invasion. Ovaries appeared normal. However, there were some subcentimetric lymph nodes in the external iliac and obturator and inguinal regions. So the first question is to Dr. Bhagyalakshmi, ma'am. How would you proceed, ma'am?
Yeah. So I think she's 32 years and nulliparous, right?
Yes, ma'am.
And she's grade 1, and the only thing which is against fertility preservation here is myoinvasion.
Correct.
So I think at the first go, I'll have to counsel the patient about that whether she is really insistent about fertility preservation or not, though it's not a standard of care with myoinvasion. But then actually many women, in spite of everything, would still consider fertility preservation. So before that, if we decide for a hysterectomy, I will really send her to a maybe reproductive physician to think about if she is married about for the embryo cryopreservation or those things, and then a plan for a definitive surgery.
Right now. So would you not consider uterine sparing conservative management in her?
Yeah, I would, but since there is a myoinvasion, that is actually not a very clear-cut indication for fertility preservation. But still, if she is agreed to take the risk, I will go ahead with a hysteroscopic resection with medroxyprogesterone and a LNG IVs.
Right now. Dr. Rupesh sir, would you like to add?
But I think I'll have to add that if feasible, we should do a molecular marker before doing this
Exactly. I
fertility
was,
preserving treatment.
yeah. So very true, madam. So I would like to also, concur with, in most of this, ideally, definitely she's not a candidate for fertility preservation at all. Especially with a 5.7 centimeter tumor, there's a
Yes.
high risk, and with already whatever 50% myelin, less than 50% they've given. You never know. Sometimes it can be more than also, but
More
so
than
the
that,
risk of,
exactly.
yeah, we don't know, and the risk of adjuvant therapy, she will be requiring it, will for sure. So we have to. I know it's difficult breaking the news to them, but I think, yeah, it's very hard to preserve the uterus in her.
Yeah, we can. If she's married, embryo cryopreservation cannot be done.
Absolutely, absolutely.
So as you correctly pointed out, she cannot be given the choice of uterine preservation because she does not belong to EIN or grade 1 without myoinvasion. So would you like to involve any ancillary specialist of significance? Madam has already answered that question. So a fertility specialist and an oncologist would be involved in the planning of the management.
Yeah.
Moving on, this is to Dr. Rupesh sir. Sir, what surgery would you plan considering the fact that she is nulliparous and desirous of having a child?
Yeah. So as discussed earlier, definitely removal of the uterus. I would recommend her. I would suggest her with removal of both the tubes. Since you said that she does not have any positive history of malignancies, I mean, no, there's no history of breast, GI, or genetic or gynecological malignancies in the first degree relatives in the family. And also, since she is 32, she's pretty young. The morbidity of oophorectomy is very high, and since it's showing less than 50% myometrulation and grade 1, so I would think of conserving her ovaries. So at least as Madam told, Dr. Bhaglakshmi Madam already told, embryo cryopreservation will definitely be suggested to her. But this is something which minimum I would do. And with regards to the lymph nodes, yes, if there's I would like to do sentinel lymph node detection in her, and address at least the pelvic lymph nodes. If there's no sentinel lymph node, at least the pelvic lymph node should be addressed. Systematic pelvic lymph node dissection. Sorry. So if there's a sentinel lymph node, I will definitely do a sentinel lymph node detection.
So next question is for Dr. Shobha Gudi ma'am. Ma'am, what would you counsel regarding future conception rates with this proposed procedure, ma'am?
Conception rates, as in if embryos are cryopreserved or oocytes are cryopreserved?
Either way, ma'am. We are going to spare the ovaries from removal.
Okay.
So
yeah. Okay. So you will have to kind of bring them out of the pelvis also, and you will have to you may have to all do transposition, etc. Correct.
We'll come to that, ma'am.
Yeah. So all that you have to do, but then one is never sure whether one has succeeded in doing everything possible. So in such cases, with a surrogate uterus, you say, no? That's what you're trying to say, right?
Right.
I think the chances should be quite okay, but it will depend on what kind of adjuvant therapy she is going to receive.
Correct.
I don't think you can give an offhand percentage, but then an infertility specialist who has experience with cryopreserved, gametes will be the best judge. So that's a very highly specialized area of practice. So in my so for me, it will be difficult to answer this question, but I can say that we can be hopeful. Giving hope is not at all a bad thing, but giving a percentage may not be very wise.
Right.
So I think it's better to tell them that because I have a definite feeling that even the most super specialist also will not be able to know this, because there's simply not enough data on this. Maybe you can say about 20% or 30%, something like that is possible, maybe. But definitely there is hope. It's not that there is no hope, because they often say that the results in a younger uterus, the chances of implantation, etc., are better than this kind of in an older age, in a 30s woman or a 40s woman, etc. So maybe in a 20s woman, it may be a better chance. Yes. I'm sorry, I'm not able to answer that better.
No, that was a
Correctly
great
pointed
answer, madam.
that
Very, very aptly.
it's an apt answer, because that is what we face in the OP clinic. So, like you correctly pointed out, the transposition of the ovaries would significantly add to the quality of the eggs, and chances of poor or ovarian reserve would be reduced. So that is one point we need to consider while planning the surgery as well. So in our patient, we did a total laparoscopic type 1 radical hysterectomy, bilateral salpingectomy. We addressed the pelvic lymph nodes, and we did an ovarian transposition. So her histopathology came back to us as a well-differentiated endometrioid adenocarcinoma, grade 1, with over 50% myoinvasion, with cervical stromal involvement, both of which weren't mentioned on the imaging studies. There was no LVSI and no nodal involvement. So she was upstage to stage 2A. So the next question is to Dr. Santosh, sir. Sir, would you like to do any additional tests for her?
Discussed previously, this is the apt patient where the molecular pole and the IHC for the P53 and the MSI would be very useful for further decision making.
Right. So yes, so we would like to order these panel of tests. So what is the significance, sir? How would it help you?
So pole mutation, is it positive for pole mutation here? No.
No, sir.
Okay, so again, this is a hierarchical testing that we use. First, we need to look at the pole mutation. If the pole mutation is positive, then we don't have to look at anything else, as was discussed in the previous talk. If the pole mutation is negative, then comes the MSI IHC testing that forms the intermediate group, and the P53 comes subsequently. If the MSI is negative, then you do P53. Where if the P53 is positive, it falls into high risk group. And then we further risk stratify based on the ESMO guidelines that was shown previously by the previous speaker.
Right. So our molecular test reports came out as pole mutation negative, MMR proficient, and P53 negative. So the next question is to Dr. Ajay, sir. What adjuvant therapy should be given to her, sir?
So she will fall in the intermediate group because it is stage 2. And grading is what actually? Grade 1 or grade 2?
Grade 1.
So it is stage 2 and grade 1, and there is no LVSI. So it is an intermediate group where we can recommend only vaginal brachytherapy for her. And she is less than 60 years, right?
She's 32, sir.
Yeah, so this is one thing that if it is less than 60 years, There can be an omission also of radiation brachytherapy, but this is still level 3 evidence there. I mean, I would really go ahead and give a brachytherapy, vaginal brachytherapy at least, yeah.
Right, sir. So she would need
Why?
adjuvant.
See, EBRT is something like very before we were giving it to all stage 2 where there is a cervical stromal infiltration. We would treat it like a cervix actually. But there is a subset in the newer thing where if it is stage 2 and if it is grade 1 and if there is no LVSI, then probably you can go get away with the adjuvant brachytherapy only. This is in the borderline. So one can, yes, definitely if it is stage 2 and if it is grade 2 and grade 3, there is no doubt that you have to give EBRT followed and also brachytherapy. But this is G1, so that is one thing which is on the borderline. It's very difficult. I mean, we can omit or we can not omit. If you go back to the guidelines also, if you can see that if it is stage 2 and if it is G1 and no LVSI and all nodes are negative, maybe brachytherapy should be sufficient.
Yeah, if I remember, we also did one L1 cam for her.
Then it is, yes. So any group like P53 is positive or L1 cam is positive
No,
or
L1 cam was negative for her. So that's the reason I think she was suggested by the radiation oncologist only to adjuvant brachytherapy, as you very aptly said. Yeah, yeah. So she was L1 cam negative also because the post-op change of the dilemma was earlier it was 1A radiologically, that is less than 50% myometal emission, but post-op it straight away became 2A. So that is the reason there arose a question wherein what should we do about the ovaries? Because the ovaries were preserved in her. So that is when we did an L1 cam. And for L1 cam, since it was negative, we continued to not address the ovaries again because this was a very tricky situation. So, but then yes, again, with regards to the our radiation oncologist also suggested that only a vaginal brachytherapy would suffice because of the absence of LVSI and all nodes being negative.
But yeah, this is a little bit of a borderline kind of a situation where whenever there is a cervical involvement, it is like carcinoma cervix kind of an involvement. And beyond that, we don't know what is the extension. So always it has been traditional that we do external radiation and brachytherapy for a cervix involvement. But recently, the things have changed where if it is a G1, grade 1, and focal LVSI or no LVSI, this is a category where you can get away and do only brachytherapy.
Okay, great. Thank you.
All right, sir. So moving on to the next case.
1 minute. Can I have Prerna one question?
Sure.
From the radiation oncologist.
Yes.
I just wanted to know about brachytherapy.
Yeah.
Does it have any impact on ovarian function, long-term outcome?
Where is the transposition done, ma'am? Where it's outside the field, where usually it is done?
It is usually done to the bilateral paracolic gutters.
Yeah, so that should not at
Very
all
high
affect
up.
anything.
Exactly, it's very high up.
Yeah, it should not at all affect. Even for that matter, there is some clarification which I need to give that if the nodes are negative, there is essentially no need for treating the nodes. This has been a misconception everywhere because they don't tell us, radiation oncologists during our teaching, that whether the pelvis has to be addressed or not. So if the nodes are negative, there is no essential, even if this was for a EBRT, say it was a 1B G3 or stage 2 G3 or something like aggressive histology, the nodes, if they are addressed and if they are negative, then only the vault area plus 2 centimeters around are at the CTV, that is a clinical target volume, which is at risk. So essentially, we don't go and treat the nodes unless it is positive or if it is substantial LVSI with a high risk features. So whenever the nodes are not addressed, it is more of a local area and the dose fall-offs are much I mean, confined to the vault plus 2 centimeters. So I don't think so there will be grossly any issue with the ovarian thing. Yeah.
Yeah, thank you. Thank you.
Thank you, sir. So moving on to the third case. Our third patient was Mrs. 65-year-old postmenopausal lady. She came with postmenopausal bleeding of 2 weeks. Endometrial thickness was 5 millimeters, and hysteroscopic biopsy showed serous carcinoma of the endometrium. On MRI, it was a 1.7 centimeter endometrial lesion with myoinvasion less than 50%. Left-sided pelvic nodal enlargement was noted, and there was no ascites. So the first question is to Dr. Bhagyalakshmi ma'am. So any additional tests would be required in her case?
Yeah, so right?
Ma'am, your voice is getting.
Yeah, I know my voice will be breaking. So I think a hysteroscopic guided biopsy needs to be done first. So I have to confirm that what's the grade of the tumor, send her for molecular profiling. Or please take the question, Rupesh.
Yeah, yeah. Basically, Prerna, could you just go to the first slide? I mean, I just missed. Yeah, so 65 out of postmenopausal bleeding 2 weeks, and yeah, 5 millimeter and hysteroscopic. Okay, it confirms serous carcinoma. Yeah, the moment it is serous carcinoma, and yeah, we will have to. It is an aggressive variant, so maybe I will additional tests. Maybe I will try to get one CA-125, because elevation of CA-125 in such scenarios can be an indication of extra pelvic disease or extra nodal disease. So I would like to get the CA-125, maybe one
Right.
thing. And yeah, the other molecular, anyhow, the high chances that she would be P53 positive. And so I would like to do all those things on the final histopathology report, maybe. So this is what it is.
Sir, how would you counsel for the surgery, sir?
Yeah, surgery. We have serous carcinomas. We'll have to do a complete 65-year-old lady. I would like to do at least, yeah, an extrafacial hysterectomy with bilateral salpingo-forectomy, both pelvic and para-aortic nodes, and an omentectomy, as well as any suspicious peritoneal nodules, or suspicious peritoneal, you know, places, suspicious peritoneum rather. So I would like to biopsy that also. So because there is a chance that serous cancers can have a transperitoneal spread. So yes, you have to do a thorough inspection of the peritoneum. So this would be definitely a staging laparotomy, as what Dr. Shobha Gudi madam said that time. So I would like to do it and complete it, document it.
Sir, is there any role for cytoreductive surgery?
Yeah, exactly. I mean, whenever there's advanced disease, when the CA-125 has increased, or when the imaging is showing some extrapelvic disease, when there's peritoneal nodules here and there, or omental caking is there, omental shrinking is there, then we will have to cytoreduce all that. So you got to cytoreduce, in the sense, remove all that, because I operated maybe last year, or less early this year, like two cases were there, like both presented in with a lot of advanced peritoneal disease. One was serous, and one was a clear, serous plus a combination of willow glandula, something like that. So yes, you tend to do a cytoreductive surgery. It may be you have to remove all the disease, if you decide. And the clear cut guidelines is that if there is already extra pelvic disease, firstly, an expert gynecologic oncologist with a proper radiological assessment. The radiologist also, in concurrence with that, you have to decide whether she's upfront operable or not. Only then you have to go ahead. So only then you have to do. But if there's extensive disease, then maybe you'll have to resort for chemotherapy. I'm sure Dr. Santosh will have his opinion on that. So yes, in this lady, yes, this is all I would like to do.
Sir, in what other histology would you do infracolic omentectomy?
Yeah, in grade 3 endometrioid, in clear cell carcinomas, all these aggressive histologies, would like to do, intracolic omentectomy as well. And
yes, sir.
carcinosarcoma, I'm sorry. Yeah. Carcinosarcoma, yes.
So apart from serous cancers, these are the other cancers.
Yeah.
You've already answered this question. So in our patient, what we did was type 1 radical hysterectomy, BSO, infracolic cholecystectomy. We addressed the pelvic and para-aortic lymph nodes, and we took peritoneal washings. So histopathology was reported as endometrial adenocarcinoma with 95% serous component and 5% endometrial component. 2 of the 42 nodes that were dissected were positive. That was the right external iliac. Rest were negative. So she was staged as stage 3C1 2. So the next question is to Dr. Aparna ma'am. Ma'am, what would you request any additional tests on the specimen?
I suppose P53 has already been done to confirm serous.
Not yet.
Okay, then we will require a P53 to confirm the serous.
Right. So additionally, would you do ERPR HER2/neu testing?
No. See, the pole mutation, MMR, P53, the standard. But those come under prognostic category. For diagnostic, just P53 to confirm the serous carcinoma.
Right.
Many times, serous carcinoma can mimic a villow-glandular carcinoma, which is a grade 1 endometrioid. Many times, they can mimic each other. So P53 would put all the doubts to rest. Although if you look carefully, serous will have very ugly, serous carcinoma will have very ugly nuclear morphology, but on a superficial glance, many times we do get second opinions where a villow-glandular carcinoma has been overdiagnosed as serous.
Right.
So it's always better to do P53.
Right. Moving
just
on.
a word of just a doubt to Dr. Aparna ma'am. Like, now since it's like serous, maybe what about like HER2 testing, because there's also a role of
Prognostic, that will not be diagnostic. Yeah, HER2 is done. Prognostic.
Okay. You can do is prognostic. Okay, take care. Thank you.
So, next question is to Dr. Ajay sir. What adjuvant therapy would you plan for her, sir?
So clearly it is a high risk serous carcinoma. So there is definitely a combination of radiation and chemotherapy. So the sequence will come, but as far as radiation is concerned, she will require external radiation therapy to the vault area as well as the lymph nodes, because 2 lymph nodes are positive. Now, whether to give what are the lymph nodes to be involved: internal iliac, external iliac, and common iliac and presacral. Now, if the lymph nodes were positive in the common iliac, then you have to go ahead and also treat para-aortic, lower para-aortic, and the dose would be for 50.4 gray in 28 fractions. This is the external radiation, and the technique, of course, 3D CRT would suffice. But definitely IMRT has a little edge over it in preserving the bowel. That's the only thing. Otherwise, 3D CRT or IMRT, or even for that matter, advanced rapid art can be offered to her. No great advantage of rapid arc over IMRT, but yes, there is a minimal bowel benefit with IMRT over 3D CRT, and followed by brachytherapy. Now the brachytherapy dose will be so 50.4 external you have given. You have to take the dose to up to 66 gray. So you can give around 5.5 gray in 3 fractions to the vault, usually prescribed at 0.5 centimeter depth. So that is how we do the brachytherapy, and we measure the diameter, and so it's external radiation and brachytherapy for her. And during external radiation, we can combine with the concurrent platinum, and she will also require adjuvant. So sometimes we sandwich it. We start with the chemotherapy, and then in between we incorporate the radiation, because serous, as we know, that it is stage 3, and there is a propensity for systemic metastasis. So we give prominence to chemotherapy first. But of course, Dr. Santosh will answer that. So she will require a combination of both. And from radiation perspective, she will require external and brachytherapy.
So yes, sir. So she will need both brachy and EBRT. moving on to the next question for Dr. Santosh. Is there any role of chemo in this case and in this particular case, and if it was in stage 1, in 2 scenarios?
This case would definitely give chemo. We follow the POTEC 3 regime where we give CTRT first, followed by 4 cycles of adjuvant paclitaxel carboplatin. What we generally do, because there is along with radiation, there is some cisplatin going on. We tend to do the radiation first at our institute. With respect to if it was a stage 1 disease, I'm not too sure if it's a surgery fully done, if there is any role for chemotherapy. Even if it is a P53 mutated, I don't think there is any recommendation to do chemotherapy. Hello.
Dr. Prerna?
Yes, sir. So how would you want to schedule the chemotherapy? I think you already answered that question.
Yeah.
Rupesh, can I have a word, Rupesh? It is nearly
Please, madam.
11 p.m. It's 5 minutes to 11, I think.
No, we are almost done, I think, madam. Dr. Prerna, are we at the finishing the panel?
We are at risk of being called the midnight webinar.
True, madam. Dr. Prerna, how many more slides, ma'am?
Sir, last slide, sir.
Okay.
This is the last slide. This is to Dr. Aparna. Sorry, this is for Dr. Ajay, sir.
Yeah.
So, would you expect any failure, sir?
I mean, it's very difficult to say, yeah, because it's already a stage 3C and definitely notes are all positive. So there can be a failure in it can metastasize and have a failure. But yes, if you do a good staging and good chemotherapy and radiation therapy, there is also positivity of it, let's say around usually we can get around say 65% to 35%, probably 35% failures. That's what I would predict. And the common site of recurrence would be probably lung and also the peritoneum. Yeah.
Okay, sir. Thank you, sir. So the take-home points are to work up the patient preoperatively, find out the grade and cell type on histology, if possible LVSI, ask for the appropriate imaging, the size of the lesion, myoinvasion, lymph node status, and any other metastasis. So preoperatively decide the stage on radiology and the extent of surgery needs to be planned. So on final histopathology, certain things need to be asked for, and the molecular classification needs to be decided, and then decide on the final staging, stratify the risk, and offer adjuvant treatment. So these are my references. Thank you all for your
Hello,
time.
Dr. Ajay here. See, I just want to make a quick point for the gynecologist actually. See, whenever we do only vaginal brachytherapy, right, in the intermediate group, there is always a notion that only 3 brachytherapy sessions are enough. It is not enough. You might have to give 5 brachy sessions because the vault requires the same dose of microscopic dose as the external radiation. So, if it is vaginal brachytherapy, it has to be at least 5 gray in 5 fractions or 5.5 gray in 5 fractions, which is equivalent to around 50 gray when we would have given an external radiation. But when there is an indication like external plus brachy, then you would have already given 50 gray. So only 2 to 3 brachytherapy sessions should be enough. So whenever we combine with external and brachy, then it is only 2 or 3 brachy sessions. But when we are giving only brachy as the treatment, it has to be at least 5 sessions.
Okay, that was a revelation. Thank you so much. We didn't know. I mean, especially when most of the times we see this 3 cycles are enough. Anyways, thank you so much for that, Dr. Ajay. I mean, if on the closing remarks, it was a great learning I'm sure it was a great learning for all of us. This webinar was mainly intended as June was the Endometrial Cancer Awareness Month, but unfortunately we couldn't find time to have this webinar in June, but we had it in just early July. I'm sure that every single gynecologist will be taking home a lot of information today with regards to the stratification, the risk stratification, the grades, the usage of the various pathological aspects that we need to know, the importance of various molecular markers and all these things, and of course the newer management guidelines. So definitely this was very insightful. Thank you everyone, Dr. Sarita Madam,
Yeah.
Dr. Aparna Ganguly, Dr. Santosh, Dr. Ajay Rao, everybody, Dr. Shobha Gudi Madam, of course, she's our secretary from Kasoga, and thank you, Madam, for the opportunity.
Rupesh, I
Dr.
wanted to
Bhagyalakshmi
say,
Naik as well.
I wanted to say that you have done an excellent job, very, very good. You know, you got together very key faculty for this discussion. It was a much needed discussion because of the recent developments. So many new things for everyone. And I must compliment Prerna. She conducted an excellent panel. You know, she had, I'm sure she was guided by you, but then also.
Thank you, ma'am.
Thank you so much, Madam. Thank you. Thank you for all the encouraging words.
Yeah, very
And
nice.
yeah, yeah, without much delay, wishing a good night to everybody.
Thank you,
We'll again,
Rupesh. Before my line gets said, thank you, Rupesh, Dr.
Madam,
Shobha, and
Madam,
all of you.
yeah, your
I
line
wish
Hi,
might
yeah,
have.
thank you.